a total of 26 member states have now reported the occurrence of the B.1.1.7 variant in their countries. And a very similar number, 25, have reported the presence of the B.1.351 variant. Guinea-Bissau is the new addition, new added country for having reported this variant, that is the B.1.351 variant. Two additional member states, that is Botswana and Zambia, have now reported the B.1.617 variant, which is the variant that was originally reported or identified in India. And now that brings up to a total of 9 countries that have now reported the presence of that variant in Africa. And because the number is still small, I can read them. That includes Angola, Botswana, DRC, Kenya, Morocco, Nigeria, South Africa, Uganda, and Zambia. Again, before I transition from this variant mapping, I just want to say that the way this virus circulates and transmits suggests that it's a question of time before these variants will be spreading more extensively across the continent. And we can discuss that during the question and answer phase. So what are the trends we have seen in the last 1 week across the continent? So if we look at the epidemiological week 18 and compare that to the epidemiological week 19, which is this week, we notice that a total of 56,000 new cases have been reported to this. And this accounts for a 6% decrease from the previous week. In terms of that, a total of 1,800 new deaths have been reported across the continent, and that represents a 12% decrease in the number of new deaths across the continent. If we now look at the 4 weeks trends, that is the period between 19 April and 16 May, we notice the following: a 9% overall average decrease in new cases in Africa, with the following regional trends: 26% increase in Central Africa, 13% increase in Southern Africa, 11% decrease in North Africa, 14% decrease in West Africa, and 19% decrease in East Africa. In terms of new deaths over the last 4 weeks, we noticed that an average of 4% average decrease in deaths have occurred across the continent, with the following breakdown by the most populous countries: 11% average increase in Egypt, 8% average increase in South Africa, 13% average decrease in Ethiopia, 5% average decrease in Kenya, 19% average decrease in DRC, and 50% average decrease in Nigeria. In terms of testing, over 46 million tests have been conducted across the continent, and 696,000 new tests were conducted or reported in the week 19, that is between last week and this week. Unfortunately, this represents a 6% decrease in the number of tests. The overall positivity rate still stands at 10%, to be specific, 10.2%. Africa CDC continues to support member states to distribute 700 oxygen concentrators and accessories to 26 member states. Again, this is in line with the adapted strategy we announced last week following the meeting of May 8, which calls for a shift in our strategy to focus on enhanced prevention, enhanced monitoring, and enhanced treatment. And underneath that enhanced treatment, we really are pushing for countries to have adequate stocks of the oxygen concentrators. So I'm very
for other provinces that have not yet completed, and probably when they complete all this number might change, and we'll have results on that. But also, we've made a comparison between the gender, the female and male, and if you see, for Sierra Leone and Zimbabwe, you have more prevalence of the serosurveys among female compared to male, which is about 40% higher than among female compared to male. For Uganda, there's no significant difference between the female and male in terms of the positivity of this serology. And also, you also see, which is in contrast with Sierra Leone and Zimbabwe, for Zambia, you have more male presenting with higher seroprevalence compared to female. So for Malawi, they had tested about 1,020 individuals, and still the process is ongoing. We didn't present the data here because it's still ongoing. And among those, 111 tested positive, which is almost equivalent to 10%. But again, we'll present their results when they finalize that and to have an official clearance from the country in terms of how many tested positive. So this is a slide that also presents some seroprevalence in Nigeria. And Nigeria also are doing several states, but here will be presenting only data for 4 states that have already completed their data collection, and they are also completed data analysis, of which, if you look for the 4 states, the overall seropositivity is ranging from 8.8% to about 23.4%. And if you look on the graph on your left, you'll see that you have mostly, apart from the 2, especially for the 2 states that have a higher prevalence, you have more females with a higher prevalence compared to males, while in Gombe and Nasarawa, you have more male positivity compared to females. So on your right-hand side, if you see that graph, it really shows that we have more positivity in urban areas compared to rural areas. So that means most of people tested positive within the rural area, within the urban area when you compare to rural areas. And this could also be explained by the mobility and the complexity that is involved with the urban settings compared to rural settings. So as per age, if you look for age groups also, you see that you have most of people, the age that has more higher positivity rate is the age between 18 to 64, and then the other one between 10 to 17. And the lower age, especially those less than 2 years, have been presented with a very low positivity rate of this. So as a takeaway message, I would like to emphasize on 4 things. Number 1, we have a very wide variation in terms of seroprevalence in these few countries that were presented here. That range from around 3% to almost about 23%, means about 23 out of every 100 individuals within this country, these places where the positivity is around 23%, have previously or currently been exposed to the virus. So with this also, it takes us to the second point, that we have still a significant proportion of African population that remains susceptible to the virus that causes COVID-19. And this will require us to invest on mechanisms to regenerate critical evidence that will guide on response strategies, especially covering the susceptible population through prioritization of interventions, including the rollout of the vaccine that is ongoing. But also, this emphasizes also, because of the higher population that is still susceptible, that African government need to really commit on scaling up the COVID-19 vaccination to protect the population and reduce the risk of developing the COVID-19 variants, especially the new variant that are circulating, as well as emphasize on ensuring that we use sero-survey data to serve as a baseline to measure effectiveness of vaccine and rollout, and to be able to see if all these interventions are very effective, and to be able to measure at the end what we've achieved with these different interventions. Over to you, Madam Wynne, for the next.
Thank you very, very much, Dr. Justin, for that presentation. Now, colleagues, we've come to the section where we take your questions so that Dr. John, Dr. Maeda, and those country representatives can respond to them live on this platform. As we indicated at the beginning, please do indicate who your question is directed to when you pose your question. And also for colleagues joining us online, please remember that this is an event for media. It is a press briefing, so kindly allow only the media members to put forward their questions. And in doing so, they should indicate their names and the agencies that they're representing. Okay, we move straight into our question and answer section. And the first question that we have, let me just locate it. It is coming from Sophie Mukwena, who is with SABC. And Sophie is the news foreign editor. So she says, there are reports that people who have been vaccinated actually test positive for COVID-19. Can you share information on your observations and what could be the reasons for such cases? I think this one is for you, Dr. John.
Thank you, Sophie. And let me repeat what I've said and what we all know, that vaccines do not prevent anyone from being infected. They prevent you from developing severe diseases and death. So that is why we continue to urge that even if people are vaccinated, you should continue to wear your mask. And if you look at those people that have been infected and actually turn out to be PCR positive, that is positive by the molecular test, they likely were not sick. And even though the literature have also shown that some people actually get sick, but again, you don't get the deaths do not occur from that. I think that's a good thing. So the vaccine do not provide absolute protection from infection, okay, but do protect you from developing disease and subsequently death. And we continue to monitor that on the continent, and we, Africa CDC, will be establishing with other member states a surveillance program to track and monitor those who have received vaccines and those who subsequently get infected, what you call vaccination breakthroughs.
Thank you very much. We have 3 questions coming from Yidnak Lema, but I'm going to take 2 in the interest of time. So Yidnak says, my name is Yidnak Lema, and I'm the journalist for the Associated Press, as well as a freelancer for CGTN. Then he says, I'd like to ask Dr. John Nkengasong the following questions. In your opinion,
prepare countries so that they can receive these vaccines and use them quickly. And listen, we are at war with this virus, and anything that you can use quickly, we better do. I mean, and what our colleague from Malawi said is very important, that in excess of 85% of their vaccines were used. Okay, that is very, very positive news. And again, what we continue to maintain and insist is that the Serum Institute had given a certification that shelf life could be extended to the 13th of July. So, but we should look at a bigger picture, because vaccines are only now beginning to be rolled out on the continent. And the issues of whether countries use vaccines quickly will come up over and over. I mean, that this is not just going to be the first time. The doses that were shipped out, they were very early doses to actually test the waters, and bigger doses will come in. But the key thing here is to focus on what Malawi did is within about 2 weeks or so, they were able to use up about 85% of the vaccines. That is very, very good news. The other thing we should be focusing on is preparing countries in such a way that they just replicate what Rwanda did. So within a week or so, Rwanda was able to use all its 290,000 doses of vaccines. I mean, that speaks to the reflexes that we should have in times of this pandemic. This is not an immunization against polio or cholera or measles that we can take time to do it. It has to be at speed and it has to be at scale, which means every member state must be prepared such that if they say you get vaccines today, you should be able to mobilize and get yourself into full swing and start using the vaccines so that we don't get into arguments of who delivered the vaccines, who didn't use the vaccines, and whatever. I think it doesn't reflect the spirit of the urgency that we are in now. And if countries, again, this is my general advice, not to the Malawi situation, if any country receive vaccines and they find themselves in a position that they anticipate they cannot use it, they make a call to whoever donated early so that they can redistribute. DRC did just that a few weeks ago, and their vaccines were taken out of that country and redistributed. So I think we are in a situation where the vaccine market is extremely, extremely limited. The virus is raging, and we should just use all the tools in our disposition when they're available to continue to fight the pandemic.
Thank you for that. We have a question from Bert Mensing from the ZDF German TV based in Nairobi. And so Bert says, is there any news about how and when member states will receive more doses of vaccines? And he's asking this in the context of some countries having already used up their available allocations.
So as I've said this week and last week and the previous week, those doses that were distributed extensively across the continent came from the COVAX facility. And I'm sure you do, all of you on this platform do briefings with the COVAX facility in Geneva. It's to really, I mean, they are better placed to address that question with respect to when countries can expect additional doses there. I can only speak authoritatively with respect to the vaccines from the AVAC mechanism, which is the African Vaccine Acquisition Task Team. And just repeat what I've said many times, that vaccines from that facility will begin to be distributed beginning the first week of the third quarter. And so we are basically about 2 months from that when those vaccines from the Johnson & Johnson will begin to be distributed. And we are preparing, working very hard to make sure that that is delivered. And with some luck, some early doses may be available, but not in large amounts. The vaccine situation is extremely challenging for us as a continent. We remain hopeful also that the positive signals that we are hearing from countries that that had acquired large amounts of vaccines are ready to begin to redistribute. I think I read that the United States is ready to redistribute about 60 to 80 million doses of vaccines. France has also committed to redistributing some, and we just hope that that can be done quickly so that we do not run into a gap between now and August when our doses from Johnson & Johnson will begin to kick in.
Thank you for that. Let's go live and invite Henry. And Henry is a freelancer with the Washington Post. Good morning, Henry. Hello, Henry. All right, it looks like we're having problems connecting with Henry. Let's move on to Paul Adepoju. Good morning, Paul.
Hello, good morning. Can you hear me?
Please. Yes, we can hear you. You are from the Lancet. Please go ahead with your question.
Yeah, thank you very much. Dr. John, you said the strain that was first identified in India will eventually spread across Africa. Why is this so, and what are the peculiar implications of this prediction? And earlier today, the WHO launched the One Health panel. How is Africa CDC working towards breaking the easy crossover of zoonotic infections to humans in a number of African countries? And for the Nigerian representative, I would like to ask, when was the data gathering in Nigeria done, and what influenced the study site selection, considering several epicenters of the COVID-19 pandemic in Nigeria were not included? Thank you very much.
Hello, Paul. Can I just
Hello?
ask, yes, Paul, can I just ask you to repeat that last question so we can start with that and give it to the representative of Nigeria who's online?
Okay, thank you. So I asked that when was the data gathering in Nigeria done, and what influenced the seroprevalence study site selection, considering several epicenters of the COVID-19 pandemic in Nigeria were not included?
Thank you. Can we go over to Professor Egumbo from Nigeria?
Thank you very much, Chair, and thanks, Paul, for that question. The survey in Nigeria ran in Lagos between September 21st and October 1st, and in the other states between September 27th and October 27th. We have done the survey completely in 4 states: in Lagos, in Enugu, in Gombe, in Nasarawa states. But in selecting the states, we sought to get at least 1 state in every geopolitical zone. In terms of our surveillance data, we also tried to balance states with relatively high reporting of prevalence, and as well as those with lower rates of reporting. We feel the current spread is reasonable, but are quickly making inroads in having surveys in additional states. We have concluded data collection in Sokoto in the Northwest, and we are preparing for data collection in South-South states of Delta, in the central state of FCT, and in Kano State. So indeed, we think that gradually would have had a sufficient of states covered through the survey. Again, thanks for the question. Over.
Thank you. Thank you very much, Prof. Maybe at this point, let me also give an opportunity to the other country representatives to speak to us a little bit about their participation in this seroprevalence survey. Let me start with Dr. Mohamed Bello Barry, the representative of Sierra Leone. Dr. Barry, in 2 minutes, please give us the main highlight points that you want people to take away from this press briefing today.
We randomized, we took the Statistics Sierra Leone enumeration areas that they used to conduct the DHS surveys, and we randomized those enumeration areas. We selected 120 of the enumeration areas. Then also within each enumeration areas, we randomized, have 10 households, and in each household, we surveyed 1 to 2 people in the household, and we followed the age strata that was given, and then did both the serosurveillance and did some interviews on terms of exposure, symptoms, and other things. So basically, that's what we did, and it's a representative of the whole country. Because again, Sierra Leone is a small country compared to Nigeria and other countries, but and actually with this kind of survey and sampling, we're able to sample each district in the country. Thank you.
Thank you very much, Dr. Barry. Can we have Dr. Henry Kyobe-Bosa, the representative from the Republic of Uganda? In 2 minutes, please, Doctor, can you tell us your participation in this survey?
Thank you so much, Chair, and thank you so much, Dr. John. Of course, the methodology, our methodology largely mimics what was done in Sierra Leone, but I will specifically go on to the findings, where from the response data, we see that here in Uganda, the disease, COVID is predominantly a disease of the male, contributing up to 67% amongst the reported cases. But what we see here in the survey, what we got in the survey, that the findings between male and female are near even, around 20%, which is strange. Now we need to go back and find out exactly what where this means and where this comes from. But of course, the other thing is that with 20% of prevalence in Uganda, we see that the virus penetrated much deeper than actually we previously knew. And this speaks to the importance of this kind of study. And the fact that the methodology was quite representative, close to and similar to what our colleagues in Sierra Leone did, where we used the enumeration areas that are used in the national census, and we randomly selected 215 enumeration areas. And in each enumeration area, we were sampling 24 households. And in each household, getting between 1 to 5 individuals of different age groups, and making sure that we do have both gender represented. Of course, noticing that our population pyramid is much skewed, that fewer and fewer older people above 60. We took anyone that we found in a household, and as you see that we have, of course, we don't have complete data here displayed. And that gave us a very good picture and understanding on where we are. There were no big surprises. Of course, much of the data, as I said, is not presented. Not so much surprises about the urban and rural distribution, where obviously urban distribution is much higher than the rural settings. And also here briefly again that this, we did this survey, we did a data collection between the 5th to 13th March, just before, and they were racing against time to make sure that we do have findings before we roll out the vaccination. And the other things, again, that were found, much of that data may not have been presented yet here, is that we saw nearly all age groups are affected. And
right,
much more.
Dr. Bossa, I will have to just jump in there and ask you please if you can make that presentation available to us at the end of the briefing so that everyone can benefit from it. We are running a bit short of time, so I want to move on and invite Professor Victor Mukonka, the Republic of Zambia, for your 2 minutes, just giving us the main highlights of your participation in that survey. Professor Mukonka. All right, while we are preparing to hear from Professor Mukonka, let us move on to Dr. Wenceslas Nyamayaro.
Thank you, Warren. Zimbabwe results showed a low prevalence, which means that the country might be in danger if don't have a herd immunity at the moment. But as we stand now, we are doing a lot of vaccination, and we have vaccinated quite a number. Out of the 800,000, we have vaccinated 600,000, the vaccines which we get.
Eswatini has engaged with Pfizer and Johnson & Johnson. It's a very good move and very encouraging move.